Hi, welcome. Thank you for joining us. I'm your host, Nada Youssef, and today we have the Vice Chair of Rheumatology and Director of the Arthritis and Musculoskeletal Center, Dr. Elaine Husni. And today we're taking your questions regarding arthritis, so any questions you guys may have, please put it in the comment section below. And before we get started, please remember this is for informational purposes only and not intended to replace your own physician's advice. Thank you so much for being here, Doctor.
Thanks, it's great to be here. Welcome.
Yeah, if you can just give us a few minutes just introducing yourself to our viewers.
Sure, you just made a nice introduction. I'm a rheumatologist. I practice in a rather large practice, and I love what I do. I think where I learn most is actually from the questions I get from patients, so I'm excited to hear what everyone has to ask.
Oh, perfect. All right, well, let's start by talking about what arthritis is. It's an inflammation of the joints, and it's usually very painful, correct?
So I think, people have all different types of arthritis, so it's important to get properly diagnosed of what type of arthritis you have, and then proper treatment can then help the patient the most.
Sure.
I think, pain is perceived differently by different people, so I think it's hard for me to say that everyone's going to have intense pain. I mean, there are some,
Sure.
and there's some people that just have mild gnawing pain, and some people that have intermittent pain, so I think
Sure.
it varies.
And it depends on your pain tolerance, I'm sure, as well, right?
Correct.
Yeah. Okay, well, it's hard to measure, but it affects more than 50 million American adults and 300,000 children, according to the Arthritis Foundation. But for treatment, there are 100 types of arthritis. So how do we know what kind of arthritis we have?
Yeah, great question. So as you know, we all have joints and we all want to move our joints. And when they hurt, you wonder, oh my gosh, is this arthritis? Mm-hmm. And I think the most important thing is to really think of arthritis as really many different types of diseases. So the most common is called osteoarthritis, mm-hmm. and that is wear and tear. And simply put, it's your cartilage kind of wears down and the bones in your joints get closer together without the cushioning. So that's osteoarthritis. Okay. That's the one that affects over 25 million
And that's more with
Americans.
age?
And usually we see that with age, people that may have overuse or repetitive syndromes, people that may have previous injuries, right? So those are what makes osteoarthritis more common in that joint.
Sure.
And then the whole other family of arthritis is what we call the more of the immune-mediated or the inflammatory arthritis. So those are people with, you might have heard of, rheumatoid arthritis, psoriatic arthritis, lupus can fall in that category. Sure. So those are sort of the two broad categories. It would take a whole hour for us to go through each of those. So that's in general.
Sure.
So one is sort of what we call a non-inflammatory arthritis. That's the osteoarthritis, where it's the wear and tear. Okay. And then the other group is what we call the inflammatory arthritis. Okay. And treatments are very different for
And that was actually my next question, because wear and tear is different than inflammation, so it's not like it's just one treatment for all.
Correct.
It all depends.
Correct.
I see. Okay, well, that answered my next question. Thank you. So do we know what causes arthritis, and is there a cure?
Great question. So arthritis in general, we have ideas of why patients might break down their joints and cause pain.
Sure.
In terms of knowing exactly what causes it, we are not there yet.
Okay.
So there is a lot of research going into trying to better understand who's at higher risk, who might need more aggressive treatment, and then eventually some of these arthritis can be more or less cured by surgery, so you can actually replace the joint.
Sure. Great. And besides medication, is there something that a person can do to minimize the pain?
Sure. So I think many of us do undergo maybe, just overuse or doing a little more exercise than they should have, and they get pain in their joint. And, the first thing that they do is what? They kind of hold off or stop. So there's many things that we can do to manage pain. But when you have a lifelong disease, like maybe more of an inflammatory arthritis, what do you do? Because you still have to go to work and you still have to take care of your family. And that's where it becomes a little bit more looking at education, so you get properly diagnosed, you understand how the arthritis affects you, and what you can do to manage the pain.
Sure.
And so that's really where what we spend a lot of our time in patient appointment to go over, is to understand where your goals are, and what you can't do the most, and what we can do to make it better. So we have both medical treatments, like with pills, we have injection therapies, and And then we also have non-drug alternatives, right? So we have a lot of physical therapy and rehab that we can recommend and work with a patient as well.
Great. Now, Cleveland weather today, surprisingly nice and warm, but I've heard a lot about arthritis or the weather affecting your joints, and arthritis can flare up from that. Or is that a true story? Because I kind of heard both sides.
Yeah, so that's really interesting. We actually have tried to look at that, how weather might affect, and we do know many people who say, oh, I know the rain's coming, or I can feel it in my joints before you even know what the weather is.
Right.
And how good can we be at predicting weather based on our joint pain? So I do believe that there's probably a lot to do with barometric pressure and humidity.
Okay.
So temperature and the way the weather is does change some of the atmospheric pressure.
Okay.
And I believe that many people may have changes in their joint capsule. So the joint capsule is just a fancy word for that fine lining that encapsulates your joint. And that is an enclosed space. So I'm sure that depending on the type of weather, that can maybe influence the way that your joint capsule might feel, either enlarging it or squeezing upon it. And then possibly, you know, certain people can feel a change in their joint. And those have nerve endings around it, and so therefore then can cause some sort of pain or pressure in that area.
Completely be affected.
But unfortunately, our science isn't quite there yet that we can say that people can actually predict when, or maybe how much, you know, what the temperature exactly might be based on joint pain.
Sure. Okay, and I kind of want to go over kind of like a myth buster, because I heard of a lot of conflicting things for arthritis. So I'm going to ask you some questions. Just let me know the truth. Is arthritis?
I'll
try. First of all, is it to blame for all joint pain? Is arthritis the one? Sorry, I have to actually.
Yeah. So I think that it's probably a little more complicated than we like. You know, we wish that if we had, you know, joint pain in that one area, we would just say yes, no to arthritis.
Sure.
But there's a lot of things also around the joint. So the joints do include the bones, as you think of, that helps us move, help us kind of bend, extend, and flex your joint. But there's also muscles around the joint. There's also tendons around the joint. So your joint, the musculoskeletal system, you know, sort of acts as a unit together with the bones, the cartilage, the tendons, the muscles. So sometimes the pain can be in different areas. Also, some people can be a little more sensitive to pain, where their nerve fibers can be more sensitive. So even if their arthritis might be more mild, but their reaction to their nerves could be higher, and therefore their pain threshold, you know, they can have and experience more pain than others.
Right. Great, thank you. Okay, so someone like, I actually crack my knuckles quite a bit. Does that cause arthritis? Because, you know, you hear about that, you know, when you're younger, your mom tells you not to do that, and you never know why. But is that a factor at all?
Yeah, it's interesting. You know, we know that it's quite habit forming. So we know that people that actually crack joints tends to do it under certain circumstances. So it's almost a habit forming for cracking knuckles. And really that the sound that it makes doesn't necessarily emanate just from the joint. It's actually studies have shown where the tendons can kind of slap against the bone. So it's kind of happening around the joint. So I think that's a very hard question. I think the jury's still out on whether it actually causes arthritis. As you know, there's many people that get arthritis that don't crack their joint. So I think it is difficult to, you know, pin down. But obviously it's in that general vicinity, and the noise comes from the joint. So it's you know, really natural for us to think whether or not. So it could be maybe not cracking the knuckles, but the way that they use their joint and overuse their joint could, you know, maybe contribute to arthritis in that area, but I wouldn't be able to say with certainty.
Sure, well, very good to know. Okay, let's talk about exercise. You know, it's recommended for our health, but can it aggravate joint pain for someone that has arthritis?
Yeah, I get that question every week, probably. Like, oh, you know, should I exercise more? Well, it doesn't make sense. It hurts, so I shouldn't. But actually, we are a big believer in, you know, using your muscles and your joints. We think that's how you're going to get, you know, long-term benefits in terms of function. So there are going to be times where you can't do that, right? There's going to be times when your arthritis flares, depending on what type of arthritis you have, and we'll probably advise you to modify your exercise at those times. But then there are times overall that we want you to keep your range of motion, resistance training, and keep your joints moving. We think overall in the long term that's going to lead to better function. So I think that's a two-sided question. So yes, we want you to exercise, but we also want you to modify it during certain times.
Sure, sure. Would you say something like maybe like swimming or like the aerobic exercises underwater, would that help with joints? I'm trying to think of what kind of exercises that wouldn't be too painful.
Sure. So what you're referring to is sort of the exercise that we see that is sort of non-weight bearing, right? So there are definitely exercise, exercise, that's actually a good point. I think exercise means different things to different people, right?
As long as I'm moving, it's probably, I consider that exercise.
Right. Well, I cleaned my house today, so I exercise,
that is
so
exercise.
Versus, oh man, I was only doing the, elliptical for an hour today instead of an hour and a half. I'm like, wow, So I think it is important to be evaluated for exercise. So there are therapists, physical therapists, exercise physiologists. There's many people that exercise is what they do for a living, and they can evaluate you to see what kind of exercise you might want to focus on. Is it your large muscle groups? Is it your small muscle groups? Where you are maybe weak.
Sure.
And then after that, there's also people that have never exercised before. Where do you even begin, right? So maybe they have to start with water therapy, which is what you were alluding to. Some sort of less resistance. So there's water-based therapy, land-based therapy, and then obviously there's people that are a lot more high functioning who are have been exercising lifelong, and they need to get to maybe a next level, where they can use different forms of exercise, maybe focusing on core,
Sure.
And then don't underestimate the other sort of maybe a little more non-traditional exercise like stretching and yoga, and things
walking
like that.
Up
and
the
walking.
steps. Great. Well, it sounds like there's a lot of customization based on the patient. You probably deal with a variety of patients and kind of pain.
Right. But the message is that exercise can be good, and we have to modify it and adjust it and personalize it.
Sure. It should be there. Yeah. Okay. And how about diet? Is that a huge factor in preventing arthritis? Is that true or false?
Yeah, so I think diet is something that's so powerful because you can control what you put into your body. So I do think it's a really important topic in general. Whether or not we're at a point where I can pinpoint a certain grocery list that's good for arthritis or bad for arthritis, we're not there yet.
Sure.
But I think we do know a lot about nutritional sciences now that we may not have known, before. So there are certain overindulgences that can lead to not feeling as well and increasing, how fatigued you might be, So those that really, focus on a lot of sweetened and processed foods aren't going to be as good as whole foods. So foods that that you shop for, that you need to shop for every day. Foods that really stay on your shelf for 3 weeks. You wonder, how good could it be? So you really want to have a plate full of very varied diets where you see multiple colors. Things that are whole foods, fresh vegetables. Those are always better than trying to limit the drive-through line at certain fast food. Where the salt and the sweet and the fried intake is just being less controlled. So overall, we know a lot about eating more with whole foods are going to be helpful. But as you know, that's a topic that we could spend the whole
that could be the
half
whole
hour
Facebook Live.
on.
That'd be the next one.
So I think talking with your doctor about your diet, I think, is a great start.
Sure.
And then depending on what other chronic illnesses you might have, we're going to tailor that diet as well.
And I'm guessing something that has to do with inflammation, like rheumatoid arthritis, like an anti-inflammatory diet would be probably good for that, correct?
Correct. So there's a lot looking at that. So I think the best way is really to have a more personalized approach. So I think some people that have severe rheumatoid arthritis, I think the diet will help, but they will also need some of the medications that a rheumatologist might recommend.
Right.
So it'll be a combination of things.
Sure.
And their exercise program might look differently than someone with mild rheumatoid arthritis that might be on a different medication.
Okay. Great. And then speaking of diet, though, can losing weight ease your joint pain?
Right. So I think we have a lot of studies looking at weight and osteoarthritis, which is the non-inflammatory. So we know that in osteoarthritis, that weight plays a big role in accelerating the cartilage loss, and having excess weight, I should say, can increase the rate that osteoarthritis can form. So perhaps in those patients that are overweight, that have osteoarthritis, your weight becomes a bigger priority, especially if your osteoarthritis is in a weight-bearing joint. So that means hips, knees, ankles. You might want to consider, and you do have excess weight, then that's where we will focus on that.
Sure, sure. Great to know. All right, well, I'm going to go ahead and jump on to some live questions that we're getting. I'm going to go to Kareem. Is there any more research being conducted on arthritis pain?
Yeah, so I think research means many things to different people.
Yes,
we do a lot of research here at the Cleveland Clinic trying to find many different ways to attack arthritis, trying to improve the ways that we look at, trying to improve patient outcomes. And so, many people might think of research as, oh, am I going to be a guinea pig? This is an experimental. But research really has a large set of rules behind it,
sure.
and that we only conduct research that, is really following, the, NIH guidelines.
Sure.
And so it's important to see if you qualify for a research study and to have a conversation with your doctor to see if you would be a good candidate to be in a research study.
Sure.
And if you are, we learn lots. I mean, this is how we excel in our understanding of research, is to get patients in and involved.
Sure.
But at the same time, not every clinical trial or research study is for you. So it's important to just get the knowledge. And just because you don't qualify for this one doesn't mean you might not qualify for another one. So research is sort of a dynamic process that you should be looking out for different studies.
So if the patient wants to get involved in a clinical trial, talk to your doctor, correct?
Yes.
Okay.
Yeah, so there are very strict ways that we look at which patient might respond to which trial. So it's going to be important to see if you qualify. Mm-hmm. And then also, how much time you might have at this time to participate in a trial, right? So we don't really just want people to sign on the dotted line and then decide, oh, I'm going to, vacation and, so it might not be a great time. Then you find another time. So this is all a, just really fact-finding and seeing which trial might fit for you. But I do think it's important to get patients excited about research.
Sure. That's great. And then knowing that it helps both sides of the patient and the doctors. All right, and I have Cecilia. My mother's 86 years old and her knees are always aching. Is that arthritis?
So that is something that's so hard to know, just sort of over the phone or on the internet. So one of the best ways that we know whether or not you have arthritis is actually to come to get a visit by a rheumatologist. And the reason for that is because we look at all different things. So we look at how you're reacting to pain, but we also make it an x-ray because we want to kind of look at the bones and see what they're doing. And we might want to do an exam, so we want to see what's going on in the joint, how well it's moving compared to someone else that we see in your same age group. So all of those play a role into how we diagnose. So it's not just the pain, but we might get some laboratory markers, we might get some x-rays, and we'll do an exam. So we kind of take all of that together with the patient, and then we can help diagnose more accurately.
Great. And then Jeff, I have diagnosis of RA and fibromyalgia. Are these commonly diagnosed together? What causes the extreme fatigue, and what can one do about it? Thank you.
Sure. So rheumatoid arthritis is probably one of the more common inflammatory arthritis, so one that we'll hear about a little bit more than some of the others. It is a immune-mediated or autoimmune disease, so we don't know what causes it. And some people have mild RA, some people have moderate, and some people have very severe RA that requires more aggressive treatment. One of the what we call comorbidities or commonly associated symptoms with rheumatoid arthritis can be fibromyalgia. There can be other things such as Sjogren's, where you get dry eyes, dry mouth. So there's a whole list of other sort of comorbidities or associated diagnosis that goes with rheumatoid arthritis. So if you have more than one, then we might tailor our treatment to helping somebody with not just the RA, but also with the fibromyalgia. So you might get 2 different treatments in that particular case.
Sure, sure. Great to know. And Phil, can you actually get arthritis off the spine?
Yeah, so arthritis can, great question, can, most commonly we think of arthritis as those joints that we, sort of bear weight on. So the knees, ankles, hips are common. But certainly you can get arthritis in the hands, in the shoulders, in the neck even. So just as a question, yes, you can get arthritis in the spine as well.
Sure. Okay. Great.
Low back is also a very common area for osteoarthritis.
Low back is, I didn't know that. Great. And then Barbara, what drugs are available to ease pain of arthritis?
So that's going to depend on the type of arthritis. So we have a whole list of medicines that we might use in the non-inflammatory, in the osteoarthritis category, and then we have a whole list of other drugs that we can use in the inflammatory arthritis, like rheumatoid arthritis or lupus.
Okay, great. And I have Barbara again. Can you have arthritis pain in your calves?
So calves are usually in the area where it's muscle. So you can have, a calf muscle. So, and muscles do attach to joints. So that in that particular area, I would say it's hard to get arthritis in the calf, but calves are the calf is related to the ankle and the knee. So sometimes we do have to kind of do the exam to see, what's going on. But arthritis in the calves, probably not, but there's associated symptoms.
Great. And then Kelly, I have screws in my ankle and my knee that are holding in a rod from a motor vehicle accident years ago. Recently, the screw in my ankle started hurting really, really bad, and can I have arthritis in it? I've had an x-ray that shows no problems.
Great. So this is sort of in that category that I remarked about earlier, that you can get osteoarthritis from injury as well, right? So there's many different things. You could be, you could have lifelong being, overweight that can accelerate osteoarthritis. You can have injury. So a motor vehicle accident would sort of fall into that category. And depending on how you might have, so with screws, I would imagine that they had surgery after the motor vehicle accident. And depending on, how bad the injury was and how complicated the surgery was, then that may or can determine how much osteoarthritis you can get over time. So it is reassuring that the X-ray, for example, did not show arthritis at this point. So maybe that there might be other reasons that we need to look for the pain.
Sure. Great. And Patty, how do you tell which type of arthritis I have? Which tests are done?
Sure. So when a patient comes in to have an evaluation by us in rheumatology, we don't go by just the pain and where it is, but we actually take a history and see, when does the pain affect you? So is the pain more just in the morning and really just eases up at the end of the day, or is the pain all day long, or does the pain only occur when you're active? So all of those are very helpful questions for us and help us determine whether you're, once again, in that sort of inflammatory group or the non-inflammatory group. And based on that and where they are, so are they in the small joints, or are they in the large joints? So all of these go into what we call history taking, and then we do an exam, and then we also look at labs and x-ray data, and we become much more confident in being able to tell you what kind of arthritis once we have all of those sort of checklists of items.
So you would say, like, the very first appointment, if someone's seeing a rheumatologist, what to expect? It would be first kind of like with the questions that you just mentioned. Okay, great.
Get the
and
history,
then based on that,
get the exam, and then we'll determine whether or not you do need, X-rays or labs. And the most important thing to hear, and maybe a little unsettling, is that you can actually have more than one type of arthritis, right? So there could be something going on in your knee, maybe from an injury from sports from a long time ago, but then you can also develop another type of arthritis. So it is important to know that it might not just be one type, and so in a formal evaluation would be helpful to sort all that out.
And just like you said, depending on the body part, your joints are like hiding between a bunch of stuff. You still have to literally ask so many questions, do a lot of tests to find that out.
Correct. So sometimes people can, just have their bursa inflamed. You can have a bursitis, which is a fluid-filled sac that's right next to your joint. And sometimes we could just take care of the inflammation of the bursitis, and you do much better, and it has nothing to do with arthritis in the joint, for example.
How often do you get that? Like, I have joint pain, they come to you, and then you find out it's not arthritis. It happens quite a bit.
Yeah.
Right?
So we really do need to, look at the exam, get the history, and not just go by pain itself. So pain is important to know about, but that's not the only thing that we look at.
How about carpal tunnel? Is carpal tunnel considered any kind of form of arthritis, or that could lead to if someone has carpal tunnel?
So probably not. So carpal tunnel is more to do with the median nerve. So it's just a nerve that's near a joint, so near your wrist joint. So that's why there can be some confusion. Is it arthritis in your wrist, or is it carpal tunnel? So that's a great example of some common things that are near the joint and not associated with arthritis. So that can be pretty easily, examined and looked after with a good visit.
Sure. Great. Rob, I'm having bad gout flare-ups in my foot. What are the best treatments for this?
Sure. So gout is another type of arthritis that's more in the inflammatory, category that we were talking about. So people with gout, it does affect their joint. It's actually one of the most painful, probably one of the most common things we see that actually enter into the emergency room. So we know it really hurts because it kind of stops you in your track. And gout is really due to an excess of uric acid crystals. And so our goal is to actually take a little fluid out of that joint and look at it under a microscope and confirm that this is due to gout. And once we know that, then we can treat. And it's very, very treatable.
And you said uric acid
crystals.
Crystals.
Yes.
What is that exactly?
So those are crystals. We have many different actually types of crystals that can form and cause joint pain. Gout would be the most common. The other ones that people might have heard of is pseudo-gout, which is a different type of crystal that can also cause arthritis. But gout by far is the most common.
Most common one. Great. Let's see. And then William, how do I know if I have arthritis? How do I tell the difference between pain and arthritis?
Right. So that is why we need more than just knowing about pain.
Right.
So that's going back to getting the history. So where is the pain? When does it occur? What makes it worse? That's the history part. And then we also, look at family history and things like that. And then, of course, going back to the exam and then looking at X-ray and laboratory data. And putting those together, we become a lot more confident to tell the patient what type of arthritis they have.
Great. Lena is asking, what is the relation between psoriasis and arthritis?
Right, so that's actually an interesting area for me because I study a lot of people with psoriatic arthritis. Okay. So there is a form of arthritis that can occur in people that have psoriasis. So normally, many times people don't even see the connection, so we are still trying to study what that is all about. But basically, you could have arthritis for almost 10 years before you might even develop any symptoms of psoriatic arthritis. Wow. So it doesn't always happen at the same time. And that's probably what makes it a little bit more difficult for us to diagnose. But we are learning a lot more about it. So not everybody with psoriasis is going to get psoriatic arthritis, but about a third of patients with psoriasis might end up with psoriatic arthritis.
Is this a thing where psoriasis always comes first, or it's always...
So the majority of cases, like maybe about 80% of the cases, yes, the skin condition comes before the arthritis.
Right.
In very, very rare conditions, the arthritis can occur before the skin, and then there's another 10% maybe where they occur together.
Sure. Okay. And then Sherry has a question. There's a lot of letters in here, but if you test positive RNP once and positive ANA, DNA and double DNA, does that make you positive for MXCTD and lupus? And I'm going to ask you to just define everything I just said because I'm not sure if everybody
Sure.
knows
So we
what
call that
is.
the alphabet soup. So,
okay, good.
so we do that for a living. We do a lot of autoimmune testing if we find that the patient comes in with a history that seems very probable for one of these diseases, so such as lupus or rheumatoid arthritis. We will start ordering some of those lab tests that I talked about.
Right.
And it is like an alphabet soup. And so depending on what we feel that the patient has more likely, we would order a set of those lab tests. So we just don't blankly order a bunch of every single lab test. So we do sort of personalize it to what they're complaining about. So in this particular, just sort of throwing out some of these alphabets, so a positive ANA, a positive anti-DNA, or a positive RNP. Those are all in what we call sort of the lupus family. And then within the lupus family she was alluding to, you can have an undifferentiated type of connective tissue disease. You could have a mixed connective tissue disease, which is the MCTD. Okay. So these are, in that family. So we look at these markers, and depending on how many are positive and how the titers are positive, we can then become more confident about what kind of diseases they fit into. Sure. So those are very different than if you came in for osteoarthritis. We would not order any of those tests, so it's just important to know the difference. And these markers are just helpful for us to know what kind of category you might be falling into. So they're not that definitive. So what I mean is there could be 10% of people in the U.S. population that have a positive ANA and never develop lupus. So you have to take this all together. So this isn't as simple as, one blood test can, definitely decide what you're going to have. Right. So we usually put that all in context. So we do look at the blood test, we look at the x-rays, and we look at the history as well as the joint exam itself.
Sure. And that's crazy. I mean, there are hundreds of arthritis types, and you're going through every test and based on the pain and everything. I mean, it must be really difficult. I mean,
well, it's actually one of my favorite parts of the job because no person comes in the same.
No two people are the same.
So it's fun. You're kind of a detective, and you get their history, and then so after a while, it's not as confusing, as it sounds. And I think that's what makes people maybe a little bit, not comfortable going to see because they look on the internet and they say, oh, well, I'm not sure which one I fall into. I don't even know if I should go. But really, if you are having joint pain that's lasting for, more than a couple weeks and interfering with your daily life, you need to see somebody.
Sure,
definitely. Would I come every time I just have a fleeting, 30-second of knee pain and think I have arthritis? No. So you really want to kind of think about, prolonged pain that's interfering with things that you're used to doing every day, changes in your pain pattern. Those are all important things that we want to know about and that you should get help for.
Great. All right, well, I'm going to do one more question.
Okay.
I have Mike. I was newly diagnosed with RA. I'm 66 years old and now taking 10-week methotrexate. I go offshore fishing and my wrists and hands and fingers swell and it hurts afterwards for about 3 days. Is this normal?
So rheumatoid arthritis, like I said, is one of our most common type of inflammatory arthritis. And our goal is to get people in what we call low disease activity or as close to remission as possible. So if you're taking these drugs and you're still having a lot of joint swelling and you're not able to do the things you want to do, then we would say that you may need to come in for a visit and you may need to talk to your doctor about either adding a medication, escalating to a different medication. So our goal is to always, start slow and move on up. So we don't really want to always start with the most aggressive form of medication. Methotrexate is what we call our anchor drug. It's a drug that's been around for 30 years. We're very familiar with it. It's a great drug. So I would say if every 10 patients that come in with rheumatoid arthritis, I would say more than half of them do really well on methotrexate alone. So we have that history. We know how to monitor it. We know how to treat you. But like I said, not all 10 patients are going to respond to methotrexate. So there's going to be another 3 or 4 patients that we know may need more. And so if you do, then you follow up with your rheumatologist and based on what's going on with your exam and your blood tests and your x-rays, we might decide to add a med or escalate a med, switch out a med. So there's the good news is for rheumatoid arthritis, when I started in med school, there was only maybe 1 or 2 drugs that I had to learn how to use. And now, 10, 15 years later, which isn't even that long, we have over a dozen medications for rheumatoid arthritis. So it's an exciting time for us.
For just rheumatoid arthritis, not all of arthritis.
Right. Right. There's new drugs for psoriatic arthritis, but in terms of rheumatoid arthritis, we have new drugs. So it's a good time to have RA. And we encourage people to really be able to communicate with their rheumatologist. Well, we want to know the things that you can or cannot do so that we can tailor treatment. So sometimes it's not just the x-ray alone, or we need to hear from patients. We need to kind of put all our sort of categories together: labs and x-rays and exam and how you're doing and what you like to do. So fishing, you want to do fishing. So we want to be able to get people in low disease activity.
Sure. That's great. It's
but it's going to take time.
It takes time. A lot of investigation, a lot of time, open-mindedness.
A little bit of trial and error with the medication is to be expected, and doesn't mean that you have something wrong with you. It's just how we treat. We have really lifelong relationships with our patients, and we are very used to that and very comfortable with that.
Sure. Well, you've been very, very useful. This is very great information. But before I let you go, is there anything you want to tell our viewers that maybe I didn't touch on?
Yeah, so I think the best thing to do is really to get properly diagnosed, right? So if you are sitting there with joint pain and you think you have one type but you really have another type, it's going to be very difficult because you're going to feel very discouraged by the things you read, or a patient or a friend that you have in church, who has a different type who's responding to Advil and you're not. Well, or non-steroidal. Maybe you are having a different type of arthritis, or maybe your arthritis is more severe. So the biggest message is to get properly diagnosed, see your doctor, start with the doctor that, an internist or a primary care physician, or you have access to a rheumatologist. People will get you there. You just have to get properly diagnosed and just not assume you have one type of arthritis. I think that's an important message.
And I think another one, you're saying it's okay to go to a primary doctor and complain about arthritis pain. It doesn't mean you need to go straight into a rheumatologist.
Correct. It just depends on, where you live, what you have access to, what your relationship is with your current physician. And usually if you have one of the more difficult arthritis, most people will be seeing a rheumatologist who specializes in arthritis.
Sure. Thank you so much. This is all very good information. So for our next Facebook Live, we're actually going to be talking to the director of Cerebrovascular Center, Dr. Shazam Hussain, and our topic will be stroke, and that's going to be the next Facebook Live, so make sure you guys tune in. And for more health tips information, make sure you follow us on Facebook, Twitter, Instagram, and Snapchat at cle.clinic, just one word, and we'll see you again next time. Thank you.